Thank you for viewing our webinar sponsored by Simon's VIP Connect titled Clinical Characteristics of a 16p11.2 Deletion Cohort. My name is Bethany Smith-Packard, one of the genetic counselors for Simon's VIP Connect, and I am joined by Dr. Wendy Chung, the principal investigator of the Simon's VIP study. During the presentation, Wendy will discuss preliminary findings of the 16p11.2 deletion carriers in the Simon's VIP study. This information was recently presented at the American College of Medical Genetics annual conference. Following the presentation, we invite you to submit any questions you have for Wendy through the Ask an Expert page on the Simon's VIP Connect website. Just one quick housekeeping item before we begin. We want to remind you that early bird registration for the Simon's VIP Connect family meeting is now open. The early bird registration has been extended and will be available until April 15th. After that, the cost to register will increase slightly. Please check out the link from our main website for more information about the family meeting, including the agenda and planned activities. Now it is my pleasure to introduce Dr. Wendy Chung. Wendy received her MD from Cornell University Medical College, her PhD from Rockefeller University in genetics. She is currently an assistant professor of pediatrics and medicine at Columbia University, where she directs the clinical genetics program and also performs human genetic research. Wendy is also the principal investigator of the Simon's VIP study, where she has been involved in compiling and analyzing the data that has been gathered from our 16p11.2 families. Thank you for joining me, Wendy. I'll let you go ahead and get started.
Thank you, Bethany. I'm glad to be here today and hope that this information will be helpful to you and to your families. We're going to be talking today about the individuals that are carriers for the 16p11.2 deletion. In the future, we'll have something similar focusing on the duplication carriers, but today we're going to focus just on the deletion carriers. So as many of you know, Simon's V has a long-range goal, which is quite comprehensive in terms of trying to understand 16p11.2. And just for those individuals who may not have heard me speak about this before, let me just give you the backdrop in terms of what we're overall trying to do. We're trying to really understand how the brain and behavior are working for individuals with 16p11.2 deletions and duplications. And to start this, we'd like to understand medically what some of the issues might be to try and help families and hopefully be able to prevent issues down the road, and to understand, as I said, how the brain and how behavior is working for those individuals so that ultimately we can be able to make life better for individual carriers, be able to understand what, for instance, might be more useful in terms of educational approaches, behavioral approaches, and as I'll talk about today in particular, speech and language. In doing so, you'll realize as I talk about this that we're trying to look at individuals with the deletion and compare them also to family members who don't carry the deletion to try and understand the difference between those individuals. We're trying to understand, as you'll see from some of the slides, that there is quite a bit of quite a broad spectrum in individual deletion carriers, and understand what the basis for that difference in terms of behaviors and different psychometric measures might be, and to understand how the brain works and how that correlates how the brain looks. And I'll get into this in a little bit more detail, but some of the studies we're doing in terms of the MRIs, being able to look at the brain and understanding how that fits in with the behaviors and some of the psychometric tests that we're doing. And ultimately, we'd like to understand how this changes over time, how individuals grow up with the 16p deletion, importantly, so we might be able to understand how to intervene and improve the outcome. So let me start by just trying to make sure we're all on the same page in terms of what we're talking about here. This is meant to be just a cartoon of the chromosome number 16, and we're talking about what we call the short arm or the P arm of the chromosome 16, and in the red box showing you the area of that chromosome band 1,1 and the smaller section 0.2. This I know can be very confusing for individual families as well as providers for families because there are several different deletions that are on 16p, all in the same neighborhood. And although they're very similar in terms of location, we're distinctly focusing on the region that I've shown below in what we call breakpoint 4 to breakpoint 5 region. And I realize sometimes, as I said, this can be confusing when you're reading your cytogenetics report, but we're looking specifically for the 16p11.2 deletion that's approximately 600 kilobases or 600,000 bases. And I've shown here below the different genes, 29 genes that are involved in this region. As all of you know, we've set up a website with Simon's VIP Connect to be able to help individuals with the deletion as well as family members be able to gain information. And just to let you know that this webinar is going to continue to be posted up on the website so that individuals in the future and their providers, for instance, can continue to access this information. And we'll continue to provide updates as we know more information. On this slide, I've actually shown you what many of you as participants have been part of in terms of the larger picture. As you can see, we started doing the recruitment and enrollment for this study approximately a year and a half ago, and it's really been through your hard work and dedication as families that we've been able to learn as much as we have as quickly as we have. Shown in blue are the number of individuals with the 16p deletion who have been enrolled over time. And you can see now that by approximately February, March 2012, we're almost up to 90 carriers within the families who have enrolled to do the studies. Shown in red above are the total number of families that have registered on the VIP Connect website, and that includes some families, for instance, that may be outside North America who may not be able to participate in the study, but who are still actively engaged in the community. And this is really, like I said, an important thing to see because this is a relatively rare disorder, and it's really been through your hard work and dedication that we've been able to learn what we have. Shown in the next slide is the distribution of families across the United States, and you can see that we have families coast to coast in North America and even some families in Canada as well. And I've also shown you, for those of you who may not have participated, the different clinical sites that we have where we evaluate families. Starting in the Northeast, we have a star up here in Boston at Harvard, which is one of our clinical evaluation sites. There's another star going down the coast in Philadelphia where we have some of our imaging, as I'll get into. Down in Texas and at Baylor College of Medicine, we have another clinical site. And then going out to the West Coast in the Northwest, we have Seattle, the University of Washington, where we have another clinical site, and then San Francisco with UCSF, where we have another imaging site. And we've tried to spread these locations out across the country, trying to make it as convenient as possible for families so that they have modest amounts of travel that they have to do to come to one of the clinical sites. In the next slide is the breakdown in terms of the number of patients that we have for the data that I'll be showing you today. In total, I'll be telling you about our first 52 participants within the deletion study. There are certainly many more that are in progress. Either they've been to clinical sites and their data are being entered into the study, or they're individuals who haven't yet been to clinical sites. And eventually we hope to have approximately 100 deletion carriers in the study. So this marks basically about the halfway point. As you can see so far, the number of participants we've had in the study have been largely children under the age of 18. So approximately 48 of our individuals so far have been children, and 4 of them have been adult parents. You can see that this is broken down in the children, approximately equal male and female, 52% so far in terms of male children. In the adults, 3/4 of the adults have been male so far. The last line you'll see is that in terms of age, the average age of the children in the study has been 8.1 years, with a standard deviation of 3.8 years. So in general, this represents younger children. These are not adults yet at this point, and that'll be important as I walk through some of the data. Then again, their parents, as you'd expect, an average age of 42.3 years. On the next slide, as we look to the source of the deletion, in other words, was this inherited from a parent or did it start new with the child, you can see that a little over half of the children with the deletion, this is de novo, or this started new with them. So that means that when we went back and we tested both their mother and their father, we saw that neither one of their parents had this, but for 53.8% of the individuals in the study, this actually started brand new with them. And that's not an uncommon thing for us to see. On the other hand, approximately 16 children, or 30.8% of the participants, this was inherited. In other words, it was passed down from either the mother or the father. And in 8 of the individuals, or 15.4%, we did not know whether it was inherited or whether it started with the child. And this could have been because we didn't have the ability to test the parents. The child may have been adopted, for instance, or because one or more of the parents was not available or did not agree to testing. So as you can see, again, for over half of the participants in the study, this started brand new with them. For those of you who have participated or heard about the study, you'll realize that we do quite an extensive evaluation of the individuals, and we appreciate very much everything the families have donated in terms of their time and effort. We know this isn't an easy study. It's quite extensive, but we hope you appreciate the information that we've been gaining from this. We start out by doing this by taking a medical history interview, and this is something that the genetic counselors talk to the parents, oftentimes the mother, to try and understand what the issues have been for the individual with the deletion. We try and go back and collect medical records, and I know this is very valuable in terms of being able to substantiate and document some of the very specific medical findings that we have. And we do this because we like to be very precise about this to try and help other families in the future. So we like to make sure we get the anatomy correct, get the terminology correct, and can see how extensive some of these things are that we're reporting. In addition, we've gone back and collected the growth charts on children over time, when possible, from the time of birth through their present time. And as I'll show you, that's to try and understand how they're growing, because how they're growing tends to be one of the things that we can see a difference in for these children. In addition, we get information about family history. This is helpful, as I spoke about, to try and understand whether the deletion is inherited for that individual or whether it started new with them. And that ties in with the genetic family characterization. In addition, we take photos of the children, and this is because there may be distinctive facial features, and we're trying to understand whether or not that's the case, which will help other doctors in the future be able to diagnose the condition more readily. In the next slide, I've summarized the information that we've obtained from the medical history interview as well as from reviewing the medical records. And this is basically about the medical problems that the children have had. And it's starting from the most frequent conditions at the top of the slide, going down to the less frequent conditions down at the bottom of the slide. So as you can see, many of the parents have reported that their children have at some point in time been said to be hypotonic or to have low muscle tone. This has been seen in 69% of the individuals. This is not something necessarily that has been there the entire life of the child, but has been there at least at some time, and important enough or severe enough that the parents have commented on this. As you'll see, the children have had a variety of gastrointestinal problems, constipation seen in approximately 38% of the children. If you look down the list a little bit farther, diarrhea seen in approximately 25% of the children. So there have been an GERD, or gastroesophageal reflux disease, in 28% of the children, a variety of gastrointestinal problems. These have not necessarily been so severe that they've required medical intervention, but they have been things that the parents have noted. Another condition that's been relatively common is otitis media, or middle ear infections. You have to realize that this is relatively common in all children, so this may not be necessarily an overwhelming problem, but as I'll get to a little bit later, we have been concerned about infectious issues, and that's something that we'll continue to look for your feedback on. In addition, when it comes to neurological issues, you'll see that many parents report their children are clumsy, approximately 34% of parents reporting that their children are clumsy. We also, on the neurological exam, have noted problems with coordination, and I think those are probably the same thing that the parents are reporting. You'll also see in red that approximately 24% of the parents have noted a history of seizures in their children. And I think this is a very important point to make, because this is a larger percentage than we initially realized before we started doing this study. And it's important because the seizures can be subtle sometimes and not immediately recognized. So it's important, if you ever see that your child seems to be zoning out, seems to be daydreaming and kind of zoned out and difficult to bring back, that may represent a seizure. Or if your child is having abnormal jerking movements, certainly should be something that should be evaluated further by a child neurologist who will likely evaluate your child with an EEG or an electroencephalogram to try and understand whether or not that might be a seizure. Again, important to know because seizures can be well treated with medications, but important to be able to get seizures under control if they're present. In addition to the seizures, there are a couple other neurological findings I wanted to point out. Macrocephaly, also in red, or a large head size, noted by parents in approximately 34% of children, and I'll come back to that in a little bit, as well as hypertonia in 9%, or high muscle tone in a smaller percentage of children than with hypotonia, but still a significant percentage of the children. In addition, in red, shown that the parents have noted obesity in some of the children in approximately 19%, and I'm going to come back to that issue. Again, remember that the age of the children on average is approximately 8, and so this is something that I'll show you actually changes over time. So may be a bigger issue as the children are older rather than when they're younger. In addition, there are some problems with the skeletal system that we've noticed, in other words, the bones in the body, and these are important to note for the children as they're getting older. Scoliosis, or curvature of the spine, is seen in approximately 10% of the children, and that's important to notice because that's something that is well treated with bracing when it's necessary with surgery, but oftentimes doesn't need surgery, but important to recognize and be evaluated by a pediatric orthopedist if the pediatrician should detect scoliosis on a general examination. Pectus excavatum, or a problem with the chest when it looks like a pigeon chest, or it may be pooching in or pooching out, seen in a smaller percentage, but about 6% of the children. And then hemivertebrae, or problems with the vertebral bodies or the spine, where there may be congenital or birth defects of the spine when the children are born, and that's seen in about 8% of the children. That's important to recognize because that may be one of the factors that predisposes some of the children to scoliosis. The hemivertebrae can easily be detected by an X-ray of the spine, and so this is something that's very useful to do as a screening test with the children who have hemivertebrae being followed more carefully for scoliosis as they get older. In addition, there are some children, approximately 9%, who have failure to thrive or difficulty growing. This tends to be especially early on when the children are young. And then there are a variety of relatively infrequent but birth defects that we've seen in the children. It's not clear to us at this point because they're so infrequent whether these are actually related to the 16p deletion or whether or not these might be simply approximately the same frequency as in the general population. So this is something. As we get more children into the study, we should be able to tell better whether or not these birth defects are specifically associated with the deletion or are simply the general frequency seen in the general population. Approximately 6% of the children in the study have had congenital heart disease. In some cases, this has been relatively mild in terms of something like a ventricular septal defect or atrial septal defect. In other circumstances, it's really been a very significant form of congenital heart disease that may require multiple surgeries for correction. In addition, there have been children who've had, again, infrequent, approximately one child with each of the disorders, such as some problems with the development of the uterus and the genitourinary tract, one child that had problems with craniosynostosis, another child who had problems with the inner ear bone, the stapes, and finally one more child who had problems with the way that the back of the mouth was formed, leading to problems with what we call velopharyngeal insufficiency. Now I'm going to turn to some of the growth patterns that we've seen in the children over time, and this is a relatively complex slide, so let me walk you through it. On the left of the slide are shown the boys, and on the right side of the slide are shown the girls. In the upper part of the slide, you can see the children when they're younger. So on the x-axis of the slide shows their age, and in the top left panel, the age goes from birth, or age 0, up until age 3. On the bottom part of that slide for the boys is the same looking at the same parameter, except now the children are a little bit older in this part of the slide. And I broke this out simply because it was difficult to see all these little tiny points if we put it all in one scale. So the lower part of the slide shows the age from age approximately 0, but really age 1 is where it starts to spread out through age 16. And those ages are replicated on the right with the females. What's shown in this slide is the head circumference, and the individual dots are points, data points for children and where they fall in terms of the growth chart for the head size. And this is shown in what we call centimeters here to be able to show the actual absolute size of the head circumference. And for comparison, to see what other normal children are like, I've shown in blue what the average head circumference is for an average boy or an average girl at that age. And as you can see, head should be growing over time, so that blue dashed line increases over time. Also shown are the range of normals. So the red dots represent the lower limit of a normal head circumference size, and the green dot shows the upper limit of what the normal should be for head circumference size. So children who have dots that go below the red, we officially say are microcephalic or have a small head size, whereas children who go above the green dots are officially macrocephalic or have a large head size. Again, this is not something that necessarily is causing the children problems, but is something that we're trying to understand in terms of brain structure and brain function. What you'll notice, let's start in the upper left panel. When you look at the boys, for instance, as they're younger children, when they're before 1 year of age, they tend to have relatively normal head sizes, but they tend to be a little bit higher than average. On the other hand, as the children are getting older, again following that upper left-hand corner, the boys, as they're getting older, there tend to be a small number of boys who are officially macrocephalic or have head circumferences above those green dots. And if you look at the lower left panel, as the children are getting to be, for instance, age 6 and above, you'll notice that a significant number of the children are officially macrocephalic and have their head circumference either at or higher than the level of those green dots. So again, what we would say from this is that the head circumference tends to increase over time, and the children tend to be more macrocephalic as they get older. That is, their head size proportionately is larger as they get older. And if you follow through and go through the same exercise with the girls, you'll see that the girls follow a similar pattern. That is that when they're younger, very young, for instance, age less than 1, they tend to be within the normal range, but they tend to be a little bit greater than average. And as they get older, going down to the lower right-hand corner, above age 6, 7, many of them, but not all of them, are officially macrocephalic and greater than the normal head size. We'll move on to the next slide, and this is regarding now a measure of body size called body mass index, BMI, or body mass index. This is a measure of how heavy the children are to a certain extent. This is a measurement of the weight in kilograms divided by the height in meters square. So this is something that you could calculate for yourself or you could calculate for a child. This is a tricky measurement in children because it actually changes. What the normal range is changes for children over time. So it's a little bit more difficult for me to graph out like I did head circumference. So I've shown these data in what we call z-scores. A z-score is a standard deviation, or how much different a child's body mass index is compared to the average. So a z-score of 0 would mean that a child has an absolutely average BMI, or body mass index. A z-score of 1 means that a child is 1 standard deviation above the average, and a z-score of 2 means that a child is 2 standard deviations above the average. A z-score of -1, conversely, would mean 1 standard deviation below the average. Again, these data are shown over time longitudinally, so the x-axis is shown in years. You can see that the children range from 0 all the way up to, we've shown age 14 here. And you can see that on average, except when the children are very young, their body mass index tends to be above average. Although it's not an absolute increase in adiposity or increased body mass index for everyone, you can see that these blue dots are the average for a group at any one age. And those little black lines above and below the blue dots show us the range of individuals within that same age group. So if you look in general at the blue dots over time, I think the visual image you'll get is that as the children are getting older, in general they tend to be getting heavier. And so that, for instance, after children are approximately age 6 and above, they tend to be approximately 1 standard deviation greater than the population at large in terms of body mass index. Now, importantly, as I said from the beginning, our cohort so far tends to be mostly children, and tends to be mostly children on average age 8. So when you think about this, we don't necessarily have a lot of data on children, for instance, are much older, either older teenagers or even into adults. Although we don't have the data from our study, other study sets looking at 16p deletion carriers have shown that as the deletion carriers get to be older teenagers and adults, that they do tend to have a problem with their weight, that their body mass index can actually be greater than 2 standard deviations above the mean, and in some cases can be significantly elevated. For those of you who are adults now, we like adults to have a body mass index that's below 25. 25 to 30 is considered the danger zone in terms of getting too heavy, and greater than 30 really is something we'd like to work on in terms of bringing the body mass index. Adults with the 16p deletion have been noted to have body mass indexes that can be greater than 30, and in some of them even as high as 40. And so this is something that is really something to work on when the children are young, to make sure that they're having healthy lifestyle habits, healthy eating habits, healthy exercise habits, because that will hopefully set them up for a lifetime of health ahead. And that is something that is good for them in the long term. This is a relatively long list of different measures that we put the children through at the clinical evaluation sites, again at Boston, at Harvard, Baylor, and the University of Washington. I won't go through the results for all of these because we don't have all of these analyzed yet, but just to say that a large amount of the time that's spent at the clinical sites is spent doing these various different tests in terms of testing and evaluating the children and the family members who serve as controls. This is a plot of the intelligence quotient, the full-scale intelligence quotient, or IQ, and I've shown here 2 different distributions. In red on the left side are shown the individuals with 16p deletions, and on the right side are individuals who do not have the deletion but are from the same families. So these serve as good controls for comparison. Every one of the scale on the x-axis is the actual intelligence scale, and in general, the scale for this in the general population is a mean or an average of 100, and what we call a standard deviation, or a difference of 15 IQ points. In general, we consider that 2 standard deviations below the mean, so in other words, a score of less than 70, is considered individuals with borderline problems with intelligence. And the lower that IQ goes, the more severe the problems are in terms of cognitive ability. On the converse side, individuals that have higher IQs tend to be, have increased intelligence and find it easier to perform certain types of tasks. As you can see, there's a significant range in the intelligence quotient for the deletion carriers. It goes all the way down from approximately 45, which would be the significantly intellectually disabled, to an individual all the way up into the 120s, which would be considered significantly above average in terms of intelligence. I've also shown with the big arrows what the average for the group is, and so you can see that the mean or the average for the group with the deletion carriers is 80, while the mean for the family members without the deletion is 108. So the family members actually have a slightly increased or above average intelligence quotient overall, whereas the individuals with the deletion have an intelligence quotient that's approximately a standard deviation below the average population. Again, there's a significant range in this, and you can see that many individuals with the deletion are within the normal range, and on the other hand, there are some that have either borderline or more significant problems. Breaking this out more carefully into different portions or components of the intelligence scale. We looked specifically at the verbal intelligence quotient, or the verbal IQ. And again, this slide is set up similar to the last, whereas individuals in red are the deletion carriers, individuals in blue are their family controls. And you can see this is very similar to the overall full-scale IQ. In general, though, the intelligence quotient tends to be a little bit lower for individuals with the deletion than their overall full-scale IQ. So remember, their overall full-scale IQ was 80 in the last slide, and their verbal IQ a little bit lower, of average of 76 here. Again, you can see that there's a wide range in individuals with the deletion, most of whom are within the normal range over 70, but certainly a few individuals that tend to have more severe difficulties with the verbal IQ specifically. And then finally, going on to the next slide, I've also broken this out in terms of nonverbal IQ. So these are other tests that don't require language specifically. And you can see that the deletion carriers on average do a little bit better in this area. So their mean or their average is 83, a little bit higher than their verbal IQ. And that correlates with what we've heard from families in terms of the children having more difficulty with speech and language specifically. And that seems to be borne out by the studies now in terms of the functional testing. On the next slide, I've summarized the different diagnoses that have been given to the children as they've gone through their evaluations at the clinical sites. You can see that overall 94% of the individuals have been given some sort of diagnosis at the clinical sites. So individuals tend to have one, or in most cases more than one problem. Again, these are relatively young children, so things are still changing, and these diagnoses certainly may change over time. On the flip side, that also means that there were 6% of individuals who had absolutely no diagnoses at all. Of those diagnoses, approximately 15% of the children had a diagnosis of autism spectrum disorder, or ASD, shown on the top line there. In addition, more frequent diagnoses were things related to speech and language. So you can see that 36% of the individuals had problems with the mechanics of speech, or what we call a phonological disorder. They had difficulty with forming the sounds and the words with their mouth, being able to make the right motions. 30% or 36% of the children also had problems with language disorder, which may represent more than just the mechanics of speech, but actually problems with grammar, putting the sentence together, syntax, more sort of cognitive issues when it comes to the speech. In addition, as I said, 31% of the children had what we call developmental coordination disorder. And I think this probably correlates with what the parents are reporting in terms of clumsiness or difficulty with coordination. Overall, 29% of the children had intellectual disabilities, and that was similar to what I'd show you on the previous slides. And 15% of the children had learning disabilities. There were also small percentages, but many of the children had other problems as well. Attention deficit disorder, hyperactivity was seen in 12% of the children, as well as a variety of other problems, including disruptive behaviors in 8%, anxiety in 4%, mood disorder in 4%, and oppositional defiance disorder in 2% of the children. Finally, we've also, in addition to brain function, tried to look at brain structure to understand what the brain itself looks like. Not all of the children have been able to do this, but quite a number have been able to go into the scanner, the MRI scanner, so that we can get a picture of the brain to see how it's working. And in future webinars, hopefully we'll be able to provide you with the results of some very interesting studies about how the brain is functioning, as we've done functional MRIs and something called MEG, where we look at the electrical activity of the brain. I won't have time to talk about that today, and those studies are still in progress. On the next slide, I can show you what we've actually seen when we've looked at those structures of the brain. We've had 41 children with deletions, or 41 individuals with deletions, go through that study, and 47 family member controls that we've used as comparison. And you can see that there are 3 areas of the brain which seem to stand out in being distinctly different from the family member controls. One is the pituitary, and at this point we haven't seen, the pituitary is a part of the brain that's often involved in endocrinological or glandular function of the body. So far we haven't seen endocrinological or glandular problems in individuals in terms of reporting that from the medical history, but it is something we're continuing to look at. But the pituitaries tend to look a little bit smaller for individual deletion carriers. In addition, there are parts of the back of the brain and the base of the brain, a part of the brain called the cerebellum, and the base of the brain called the craniocervical junction that seem to be a little bit different in deletion carriers. Those are parts in terms of the shape as well as the size. And part of the problems with the craniocervical junction in particular are likely related to bony differences that we're seeing in the vertebrae, in a bone called the dens, as well as in the cranium or the skull itself. And so they may not necessarily represent brain differences, but rather the brain fitting into the skull itself and around the bones. There are certain individuals excuse me, in this slide that I'm showing you with the big red arrow that have a problem called Siringo myilia. It's a little cyst that we can see in the spinal cord, as well as problems with the brain and the cerebellum or the posterior fossa being lower than we usually see it. And again, this is something that may or may not be causing any functional problems, but something that we've seen in more than we see in normal controls in the deletion carriers. We're getting close to the end, so starting to wrap things up. In addition, many of you have been very kind to provide both blood samples, as well as 29 of you have provided skin biopsies. And this is something that we've made to the general community studying autism. We have removed all identification from this, so no one knows that it is you or your child or other family member. But we've done this because there are other individuals that are very interested in trying to develop new treatments, especially for 16p deletion and duplication carriers. And by putting these resources out there for the entire community, it's something that we hope will catalyze others to do research in this area and hopefully come up with new ways of studying the way the brain functions, as well as coming up with new treatments. So we're happy to report that we've made this available, as I said, to the community of qualified investigators who can prove to us that they're going to be doing something good with these materials, and it'll help make sure that your investment goes to many other individuals to help come up with further knowledge for deletion carriers. Way back at the beginning, I had talked in that there were 29 genes that are in this region of the 16p, and we're now starting to understand better what some of those 29 genes work. And we believe that some of these genes specifically are accountable for some of the things that you've been reporting to us and that we've been seeing. In particular, one of the most recent findings that's very interesting is that there is a gene within this region, something called proline-rich transmembrane protein 2, that has been recently associated with paroxysmal kinesogenic dyskinesia and a form of epilepsy or seizures called familial infantile convulsions. This is very important because I've seen it in a few of my patients that they can have some of these abnormal movements. That's what dyskinesia means. But these abnormal movements, sometimes I've seen it in the face. It can look like lip twitching or lip smacking, or sometimes can look like writhing or movement of the hands. And I think this may be underappreciated because it's relatively subtle. So we'd be very interested in knowing whether or not any individuals with the deletion specifically might have some of these subtle movement problems, and if you do happen to see these, actually capturing them on video would be extremely helpful to us if you see them. In addition, as I said, we've noted that approximately 25% of the individuals have convulsions, and we believe this now may be related to the deletion specifically of this PRRT2 gene. And so I think it's extremely important for parents to be aware of the possibility of seizures, and as I stated earlier, make sure that they have their children evaluated if there looks like there could be seizures. In addition, as I said, there are some vertebral or bony problems in the spine, and we believe this may be related to one particular gene, something called the TBOX6 or TBX6, that's been related to similar problems in a similar mouse model. And in the future, I think there are going to be additional publications about genes that will be related to brain size specifically, and hopefully we'll be able to talk about that more in the near future. So just to summarize, in conclusion, for the most part, I would say the individuals with the deletion are generally a very healthy bunch. Their medical problems tend to be things that are not extremely life-threatening or very serious. There tend to be not many severe birth defects that require surgical intervention for the most part in young children. However, there are some common problems that we're seeing in terms of gastrointestinal problems, and as I was stating, some parents are reporting more than the average number of infections, either middle ear infections or lung infections, and that's something that we're especially interested in watching, as well as these vertebral or bony problems that we've been seeing. Seizures are relatively common and something to be looked into. Being heavy or being obese tends not to be necessarily something early on, but tends to develop over time, and something that, again, we hope that by early intervention with this, we can improve that for the older children. Again, in terms of intelligence and verbal skills, the children tend to have some problems, but we're hoping that with early and aggressive intervention, especially in the area of speech therapy, that we can help maximize the children's function and help get them through the rough spot. In general, the speech problems tend to be early on when the children are young, ages 2 through 5, and that's the time for really being intensive in terms of the speech therapy. In addition, many of the children have a whole range and variety of other disorders that I've listed in terms of problems with cognition and behavior. And again, we think that early and aggressive intervention in terms of therapies, especially with children with autistic features, can be very helpful. To summarize this and to make it easy for doctors to remember, we've come up with a mnemonic called OCEANS, which stands for the first letter of each word, makes up the word OCEANS, stands for obesity, cognition, epilepsy, autism, neuropsychiatry, and speech impairment. And this is, we've come up with this sort of acronym or abbreviation because, again, this region of 16P can be very confusing for a lot of the doctors, and we're hoping this will help them remember specifically what this particular region of 16P is about. Again, many of these clinical features may not be very specific. It may be difficult for a lot of doctors to make this diagnosis, so we appreciate it may take a long time until families get a diagnosis, but once this diagnosis is made, I think we've got good information for the doctors and therapists and nurses taking care of these children and teachers to be able to help guide them. This is really just the beginning. Although we're about halfway towards our goal towards 100 deletion carriers, again, we need more individuals to be able to understand if some of these rare manifestations are really specifically associated with the deletion. We'd like to be able to study specifically individuals over time and see how they develop. I'm especially interested to understand whether some of our interventions are effective and which ones are most effective. So we think that that's something that's very important for us to continue working with you as long as you'll allow us to understand what's happening with the children over time. As I mentioned, we're going to be continuing to look at the functional imaging of the brain, and we'll have more to tell you about that later. And we'd ultimately like to be able to use this as one genetic copy number variant, or CNV, that we can actually use to compare to other copy number variants to understand what some of those things that are similar and some of the things that might be different, because we do realize that these different copy number variants may have different effects on the brain structure and function. Ultimately, our fantasy is that we've got some intervention that we can use to make life better for individuals with the deletion, and we hope that as we're able to develop potentially new treatments, these could be behavioral treatments, it could be medications. At this point, we don't have anything specific in mind, but we hope that over time we'll be able to come up with better treatments and offer them to you. And again, I just showed the website, the VIP Connect website, although I know all of you know this. Finally, acknowledge all the hard work and input from individuals really around the country who have been dedicated to studying the 16P deletion and duplication. I know for those of you who have been at the clinical sites, you'll recognize many of these faces. They're really a very dedicated team, and I just want to acknowledge all their hard input. I have the privilege of being able to work with all of them, but they're really the heroes that do all the work in this.
Thank you, Wendy, and thanks to everyone for viewing our webinar. Please remember to submit any questions for Wendy through the Ask an Expert page on the Simons VIP Connect website.